Hello to everyone. My name is Baldi, Domenico Baldi. First of all, I would like to thank all of you for being here to listen to my lecture. And I also would like to thank Dentalxp for the nice invitation. The topic of my lecture is sinus lift with the crystal approach. But when we speak about sinus lift, immediately we think to buccal approach. In fact, for a long time was considered as the most predictable technique to place implant in a trochic maxilla. Also nowadays, in the posterior maxilla, when implant insertion is often limited because of the maxillary sinus extension, the sinus floor elevation is a safe and popular method in order to overcome this problem and allows a implant placement. But the aim of my presentation is to show how it's possible to do in a less invasive way using crystal approach. We know that it's possible to do it with different techniques, but finally we have to obtain two basic concepts which are fundamental concepts for less invasivity, and they are therapeutical effectiveness and reduced morbidity. But first of all, we have to understand what does it mean less invasivity, in few words, when, how, and why be less invasive, in order to apply in a correct way this concept during our work. Otherwise, it remains only an ideal solution in our mind, nothing more. As a matter of fact, today I would like to suggest how to apply this principle in our daily work using a method that is not operator dependent but available to everyone. As a matter of fact, when we have a crystal approach, we must know that we do at the same moment two very difficult and different surgery in a blind way. In fact, we have to pierce the bone and then we have to elevate the sinus membrane. Therefore, if we want to reduce risk of failure and prevent complication, we have to know some fundamental factors, and these factors are diagnostic knowledge, and I mean anatomical evaluation and radiological evaluation, and instrument. Now we would like to analyze all of them. And when we speak about anatomical evaluation, we have to know, it means that we have to know where we are going to work. And I mean that in this case, we have to know the sinus. In fact, the sinus is in the body of the maxilla and has three recesses: an alveolar recess pointed inferiorly, bounded by the alveolar process of the maxilla, and zygomatic recess pointed laterally, bounded by the zygomatic bone, and in an infraorbital recess pointed superiorly, bounded by the inferior orbital surface of the maxilla. The medial wall is composed primarily of cartilage. The ostium for drainage are located high on the medial wall, and they open into the semilunar hiatus of the lateral nasal cavity. The nasal wall of the maxillar sinus or base presents in this articulated bone a large irregular aperture communicated with the nasal cavity. In the articulated skull, this aperture is much reduced in size by the same bones as the insinuate process of the ethmoid above, the ethmoidal process of the inferior nasal concha below, the vertical part of the palatine behind, and a small part of the lacrimal above and in front. If we know anatomically the sinus, it means that we know very well where we work, so we can also decide to avoid the sinus lift if it is necessary using tilted implants. The sinus is lined with mucoperiosteum, with cilia that beat towards the ostium. This membrane is also called the Schneiderian membrane, which is histological a bilaminar membrane with pseudostratified ciliated columnar epithelial cells on the internal side and the periosteum on the osseous side. It has a thickness of in average 500 microns, and if we think about this size, we can also understand immediately the correlation between membrane thickness and perforation rates in sinus augmentation surgery. And if we see this short video that we did on the cadaver, we can really see and highlight how much is thin the Schneiderian membrane in a healthy situation. And the same situation we can appreciate on our patient. Thanks to this video from the endosinusal point of view, we can see how much is thin, and we can see in transparency the light under the membrane. So we can appreciate really the good knowledge of anatomy when we pass to the radiological evaluation. In fact, we can understand in a much better way the X-ray exam, and also we can be able to plan our surgery in a correct way. When we speak about pre-surgery evaluation, we speak about X-ray, and with the X-ray we are able to take a measure, we are able to make a classification, and especially to understand the classification of the bone. I mean quality and quantity classification. We are able also to decide the best surgical technique for our patient, and then we can also decide the position and the dimension of the implants. In fact, when we take the measure, we have two kinds of possibilities. One is a bidimensional view that we can have with OPT. In this case, we can have only the length of the bone and, of course, of the implant, and we can also have the measure with the CT. In this case, we can have the three-dimensional view of the bone, and so we can have the length and the diameter of the bone, and, of course, also of the implants. And thanks to a good evaluation of the X-ray, we can also understand the influence of the anatomy of Schneiderian membrane perforation during sinus augmentation surgery. In fact, there is a correlation between the angle made by the buccal and palatal valves at crest and the membrane perforation rate. And also, we can understand how the new bone formation is influenced by sinus cavity dimension. In fact, if we have a great dimension of the cavity, we can have a lower response of the new bone. Nowadays, the market offers us a huge quantity of devices. In fact, if we analyze the instrument that we have to use during our work, we have to focus our attention on which one could be very useful for the sinus lift. And today, we want to focus our attention mainly on the mechanical instruments only, which are more commonly used in our office. And again, when we have a crystal approach, we have to know that at the same time we do two kinds of surgery. We pierce the bone and we elevate the sinus at the same time. And now we want to analyze both of them in order to understand how and what we have to use in order to work in the best way. So if we want to pierce the bone, we normally use drills and manual osteotomies as mechanical instrument. Both of them found two obstacles during our work. In fact, in the first situation, during the piercing bone, we have to understand how could be possible perforate the internal sinus bone without damaging Schneiderian membrane. And the second problem is how lift the membrane without damaging the same membrane. To resolve this problem, we use a new device, a magnetic mallet, that permit us to work without damaging the Schneiderian membrane. If we analyze motorized system, we can see that the bone is mechanical and structural anisotropic. Drill bits rotate. The cutting resistance vector is constantly changing. And if we analyze again motorized system, and when we speak about motorized system, we mean triangle and burr, we have to highlight that in order to have a good effect with any kind of burr, we need to make a pressure. For this reason, we risk to have a friction and consequently necrosis. In few words, we have a lack of precision for the rotating movement of the burr, and we have a limited control for the pressure that we do on the burr. Both of these actions are much more critical when we work on the floor of the sinus, where theoretically we should have a greatest precision, and if we have the risk of necrosis due to the friction, we can understand why this kind of approach could then be considered safe. And fundamentally so, we have a limited control and lack of precision. And if we analyze instead the manual instrument, and when we speak about a manual instrument, we speak about hand mallet, we can see that theoretically it could be a safety approach, but because we cannot assure regular continuity of hammering, when we work in contact of the floor of the sinus, instead of the plastic deformation of the bone, we have a crack with the creation of sharp bone chips, which can perforate the Schneiderian membrane. Furthermore, for the same reason, we can also say that the low force of bending waves produced by the hand mallet were found to depend on the density, moment of inertia, the elastic constant of bone. This force doesn't induce a complete bone deformation, but push forward into cranial bone, till hypertension of the neck during the operation, and displacement of others may induce binding paroxysmal position vertigo. And because we know that the bone has a fantastic characteristic. In fact, if we analyze the biomechanics of bone, we can see that the bone is flexible to absorb energy. Bone is able to change shape without cracking. Bone is able to widen in compression. Bone is able to lengthen with tension. Bone is an homogeneous, anisotropic, independent, and viscoelastic. And so it's really a pity don't take advantage from this situation. And for this reason, we have to use the right instrument for our surgery, and especially when we want to have a sinus lift with a crestal approach. In fact, if we analyze the advantages of magnetic mallet, we can see that with this instrument we can obtain bone condensing, osteodensification, rapid bone healing, precision and control implant axis, and good visibility. And when we speak about bone condensing, we can see a lot of articles that can confirm the ability of this instrument to obtain the bone condensing, as well as about osteodensification. And about rapid bone healing, we can summarize this concept with these simple phrases. Preserved bone is able to shorten healing time. And about precision and control implant axis, we can have with mallet, magnetic mallet, these characteristics, but also, as you can see in this slide, you can have also a good visibility of your work. So with magnetic mallet we can have a really good situation, good solution, because if we make a comparison between the force of the magnetic mallet with the hand mallet, we can see in this graph how the magnetic mallet forces are concentrated in a short time, in contrast to hand hammer, and so it can justify the advantages that we can have for the operator and the advantages for the patient. The advantages for operator fundamentally are more precise control of osteotome, of the entry direction, of the tip into the bone. This is an important concept, since bone is generally formed of parts with different density, and that the expander tends to be deflected when it moves from a bone part with a specific density to another bone part with a different density. And the second one is the handling of the device is very simple, using just one hand. The advantages for the patient are fundamentally made by the magnetic mallet. In fact, it improves the patient comfort, avoiding binding paroxysmal positional vertigo that we can have with the hyperextension of the neck during the use of the hand mallet. There are two types of balance organs in the inner ear, the semicircular canals and the attenuated organs. The attenuated organs contain crystals of calcium carbonate, which are constantly being shed, dissolved, and replaced by the new ones. If too many crystals fall off at one time and the patient looks up or lies down before they dissolve, they can fall into one of the semicircular canals. When the patient rises, they don't fall out, they fall in and become trapped in the canal. Upon lying down, the crystal falls through the canal, causing an intense spinning that lasts a few seconds until the crystal fall to the lowest point. When rising, the crystal fall in the other direction, which again triggers dizziness. Until the crystals are dissolved, the canal may not work properly, and the chronic disequilibrium as well as position vertigo may be present. This will continue until the crystal in the canal dissolve or are moved out of the canal with a special exercise or maneuvers. So another advantage for the patient is that magnetic mallet do not consume bone but just condense heat. So when we make the sinus lift with a crystal approach, we have to piercing the bone, but also we have to elevate sinus membrane. And we analyze all of the more popular techniques. So we know that it's possible to make this elevation with the osteotome, with manual osteotome. We can do also with the grafting material, and we can also do with the balloon inflation and with hydraulic pressure. And we analyze all of them in order to understand the advantages and disadvantages of this instrument. So if we see the osteotome, you can see how it's difficult to manage the instrument in order to have a continual, regular hammering way of our osteotome. And for this reason, we cannot control the instrument during the perforation of the bone, and especially when we are in the contact of an internal cortical bone, so we can have the perforation of the cnidaria membrane with little sharp bone chips. When we do the elevation with grafting material, of course, we have to know very well the dimension, the size of this material, because when we push this material, the internal of the cnidaria membrane, we can have the perforation. In this view, and the sinusal view, you can appreciate how very thin the cnidaria membrane. In fact, in transparency, you can see the threads of the bore during our work. And so you can understand how it's very difficult to manage this procedure. If we use the balloon, of course it could be very useful, but theoretically, because it is necessary to have a thick membrane, because this procedure, from my point of view, is too wide. And when a procedure is too wide, it's impossible to manage and impossible to have a good prevision of the situation. In fact, if we see this video, you can see that theoretically always is going in a good way, but when we finish our lifting and we take away our balloon, we can immediately see the problem that is fundamentally a perforation of the cnidaria membrane. If we analyze instead the last solution, the hydraulic pressure, you can see how it's possible theoretically work in a fantastic way. With this instrument, in fact, we can consume the bone, at the same time we can make the elevation of the cnidaria membrane. But to be honest, we need to have a thick membrane because the pressure of the water is concentrated in one place, and for this reason, at the end of our work, we can obtain a failure of our procedure. In fact, you can see here from the endosinusal view, that we work theoretically in a good way, but suddenly we have the perforation of the membrane and we have the failure of our procedure. So, for this reason, we prefer to use an instrument as magnetic mallet that permit us at the same time to pierce the bone and to lift the sinus membrane. And if we see this whole niche classification, we can understand how for a long time it was considered as valid. In fact, Misch told us that if we had a bone height of 12 millimeter, equal or greater of 12 millimeter, is not necessary treatment. Instead, if we have a bone height within 8 and 12 millimeters, it's possible to do a mini lift. If instead we have a bone height between 5 and 8 millimeters, it's necessary to have a lateral single stage. It means that it's necessary to make a sinus lift with a buccal approach, and it's possible to place at the same time the implant. But if we have a bone height of 5 millimeter or lower 5 millimeter, is absolutely for me to make two lateral approach with two stages. So it is necessary to make a lateral approach for the sinus lift, and then after the osseointegration, after the healing of our graft, we can place the implant. But using magnetic mallet, we can change this approach. In fact, when we have a bone height of 12 millimeter, we can avoid the treatment of the bone. But if we use magnetic mallet, we can obtain at the same time some advantages, and I will show you which one. Then if we have a bone height of between 8 and 12 millimeter, we can make a mini lift with magnetic mallet. And instead, if we have a bone height within 5 and 8 millimeter, it is possible to make a crystal single stage with magnetic mallet. But especially the fantastic result is when we have a bone height of 5 millimeter or lower 5 millimeter. In this case, we can have a crystal single stage with magnetic mallet. Of course, we have assured implant's primary stability. And if we analyze all of this situation, we can see some clinical cases like this, where theoretically we can prepare our implant side with the burr. But if we analyze the CT, we can see that the quality of the bone is not so good. Of course, we are working with upper jaw. So if we also made this three-dimensional virtual reproduction of the maxilla, we can understand that we can plane our implant position a good way. So we can see that if we want to place two implants in this maxilla, it could be useful to compact our bone in order to have a better condensing of the bone and also a better stability of the bone. In fact, if we make our planning on this virtual three-dimensional reconstruction, we can understand how is a good thing to have the osseodensification. In this case, we can understand in a better way how we can improve the radioconverter cure. In fact, we can, with using magnetic mallet, we can obtain a better first stability, that is mechanical stability, but also we can increase the secondary stability, the biological stability. So in this way we can reduce the gap between the primary stability and secondary stability. In this short video, you can see how we manage the situation. After a full thickness flap, we started with our insert magnetic mallet with 100, and in this way we made the first hole. Then with 200 we enlarge it, and at the same time it's possible to see how we condensed the bone and how we deformed the bone in a good way in order to have more quantity of bone around the implant. So in few words, we we have an augmentation of the transversal quantity of the bone. And this moment we place the implant and we screw the implant. And at the end of our work, we can appreciate how is the bone around the implant. So the thickness of our jaw, upper jaw, is completely changed. In this way we can be sure about the future of our work. And if we analyze the CT after the surgery, we can appreciate how the magnetic mallet was useful in order to prepare our implant side, in order to have a good primary stability of our implant, and also to increase and improve the secondary stability. So we can make a comparison with the OPT at the beginning after the surgery, and also we can see our final work. Then, if we analyze the second point, I mean when we have a height bone within 8 and 12 millimeter, we can make a mini lift with magnetic mallet. In this virtual representation, we can simplify this procedure in order to understand the surgical approach. So it means that with the mallet it was possible to use the plastic deformation of the bone in order to elevate the internal cortical bone without crack the bone, and it was possible to place our implant. Again, if we analyze the CT at the beginning, we saw how was thin the bone in the molar zone, and if we see the final placement of the implant, we can also appreciate how it is possible to elevate the internal cortical bone without a crack it. So if we make the comparison between the CT of the beginning situation and the CT of our implant plan and the final CT, you can see how it was possible to work in a really less invasive way. And again, I want to show you the surgery of this patient, and you can see how it was possible, starting with 100 instrument. It's called 100 for the dimension, of course. Then we can enlarge our hole with the 200, and in this way we can have a condensation of the bone, and so again we can enlarge the crest of the bone, and at the same time we can have the elevation of the cortical internal bone without being traumatic. And then we can place our implant. So we have the healing of the hard and soft tissue, and we can finish our work. And after 1 year, we can appreciate the final result of our surgery. Look, in this case, we can immediately understand how is great the connection between os integration and os densification. In fact, in the 80s, everyone thought that were very important the implant material, implant design, surface, condition, status of the bone, surgical technique, and implant loading condition. Instead, in the 2000s, we concentrate our attention on the bone instrumentation, and in fact we can analyze many articles where it was possible to find that the surgical technique present good prospect for improving clinical result. Nowadays, instead, we focus our attention on the os densification, and with the os densification we can have some results that demonstrate a stable marginal bone levels over time and a significant increase in bone height especially. And if we analyze another situation where we have the bone height within 5 and 8 millimeter, we can have also a crestal single stage with magnetic mallet, but in this case it was necessary to crack the cortical internal bone and to make just an elevation of the sinus membrane using the same osteotomes. Again, in this reproduction, virtual reproduction, you can understand the procedures, but I want to show you the clinical cases. And in this case, we start again with 100 osteotomes that we enlarge our hole, and with the osteotome we crack the internal cortical bone, and we make the elevation of the Snyderia membrane, as you can appreciate in this X-ray. And when we have a situation with a bone height within 5 and 8 millimeters, we can have another kind of approach using always magnetic mallet. In this case, it's not enough to crack the internal cortical bone, but it is necessary to make the elevation of a little block of the bone, and it's possible to do it in a safety way using magnetic mallet. Again, with this reproduction, we want to explain how it was possible to work with magnetic mallet. And I want to show you another case where we use again the osteotome, first size of osteotome, in order to make the first perforation. Then we use the 200, and then we use the 300, and then we use some other instrument in order to enlarge again the bone of the upper jaw, in order to have a more quantity of bone around the implant, and we make the crack of the internal cortical bone, and we move in the sinus just a little block of the bone. And you can see this procedure with X-ray, where we make a comparison with X-ray at the beginning and at the end of our work. And here you can see the final work of our surgery. And if we analyze the final situation where we have high bone equal or lower than 5 millimeters, so we can, with the magnetic mallet, we can have a crystal single stage. Of course, we must be sure about the implant primary stability. And if we make a comparison between the situation, X-ray situation, and this is the CT, we can see how is much thin the bone. Also, even if we make a socket preservation, and at this point we have to decide how we can approach this surgery. And so the analysis of the CT shows us how much thin the bone. And of course, in this case, we have to use the less invasive instrument. And of course, in this case, we need to crack the bone, to make a block of the bone, to push this block inside of the sinus, and at the same time, with the same instrument, it is necessary to make the elevation of the Snyderia membrane and place the graft material. And again, in this reproduction, you can see in a simple way how we want to proceed. And I want to show you the clinical case. We make the first hole, then with 100 osteotome we go deeper, and then we use the 200 and 300 in order to enlarge, and then we use 330 in order to crack the internal cortical bone, and then we can decide to place the first implant. And here, from this surgical view, you can see again how is augmented the bone around the implant. Then we can prepare the second implant side with the same procedure. Nothing is changed. In a very simple way, we can use this magnetic mallet, and we can manage it in perfect way. We can control our surgery. We can work with one hand, and so it means that we have a great visibility of our work. And also we can control our axis, and then and so for this reason we can correct it when we want. And when we finish our preparation, we can place the implant, and if we make the comparison between the X-ray at the beginning and the end, we can really appreciate the quality of the work that we can obtain with the magnetic mallet. And if we see this video of our surgery, you can see how it's possible to manage this instrument. We can correct the axis of our preparation. We can see in a perfect way where we are going to work. We can manage in a perfect way our Osseotouch, our magnetic Osseotouch, and you can see how this Osseotouch is very quick, and so you can see that the patient don't move the neck, so we can avoid the hyperextension of the neck of the patient. And in the end, we can place our two implants, and especially we can this kind of situation. So we can have an augmentation of a bone from the highness and from the thickness point of view. And in fact, if we make a comparison with the X-ray that we did at the beginning and the X-ray after the surgery using magnetic mallet, we can appreciate how much is augmented the bone from the highness and the thickness point of view. And this moment we can finish our surgery, so we can see the final work on our patient. In conclusion, if we look at clinical evaluation, we can summarize all the concepts which we have analyzed till now. As a matter of fact, with magnetic mallet we can obtain a magnetodynamic accurate movements, which permit us to have high control, precision and safety, especially during sinus lift with crystal approach. After this, I would like to thank all of you for your attention, and especially I would like to thank again Dentalxp for the nice invitation.